would like to thank Dr. Vijaykrishnan for arranging this wonderful meeting conference that taking place at Hyderabad. So, let me discuss a few points on comprehensive airway analysis, how we can improve our surgical outcome. We all know OSA is now a dynamic obstruction of the upper airway, and with a little component of static obstruction. We have to know the relation of the airway to the bone and soft tissue. If you consider this is a smaller bony compartment like retromedia or hypoplastic maxilla that compresses the soft tissue and compresses thereby the airway. At the same time, thickened soft tissue like in obesity that also get compressed, the airway get compressed or compromised. Sometimes in severe obese retrognathics, the situation gets worse. So proper workup is the key. So we have to know the component of static obstruction and dynamic obstruction, severity of the OSAs, and level and pattern of obstruction, so that we can plan what surgery can be better. So broadly we classify the evaluation as dynamic and awake techniques. So awake studies examine the static factors, radiofacial and soft tissue structures like lateral supplementary or CT, bone beam CT, or a 3D reconstruction of the facial-maxillary structure. Dynamic study during sleep provides the insight into the state-dependent pathophysiology, what is happening inside the airway, what happens when there is snoring and apnea. So that is more vital to further understand the sleep disorder during sleep. There are a lot of upper airway imaging techniques like simple X-ray nasopharynx, lateral supplementary, conventional electron beam CT or bone beam CT, dynamic MRI, optical coherence tomography, etc. But each has its own limitation. Nothing can be said it's ideal to completely understand what is happening inside the airway. Ideal technique should provide safe, accurate, and repetitive measurement in the supine position. Should allow for three-dimensional volumetric reconstruction of the upper airway and its surrounding tissues and radiofacial structures. Should allow for measurements during wakefulness and sleep. Here we can see a simple X-ray nasopharynx where we can grade nasopharyngeal obstruction because of adenoids, or a lateral supplementary where we can see the steep mandibular plane, a narrow posterior space, the increased length and width of the soft palate, and inferiorly positioned head, etc. We can see a lot of things. Whatever we know, we will be able to look at it. But in a dynamic imaging, like a magnetic resonance imaging MRI, sleep MRI or a dynamic MRI, it gives what is happening during natural sleep in the MRI image. It gives us both sagittal and axial view of the neck. And it is basically a balanced post-field sequence with turbo-field echo modes used to take lakhs of cine MR images so that we can combine it to form a cine MR. More than 50% collapse of the upper airway space is considered significant. And here you can see an image of a normal patient and a sleep apnea patient. You can compare posterior airway space at the level of palate, at the level of tongue base, at the level of epiglottis, and even the fat deposition inside the tongue and the chin and in the nape of neck, etc. And also you can see the lingual tonsil hypertrophy here, and the fat depositions inside the muscles can also be assessed. And if you use the software, you yourself can assess and measure the length of the posterior space at the level of velum, at the level of palate, at the level of tongue base, etc. And you can measure the length of the soft palate and length of the tongue base, etc., etc. So what all you need is you need a software to look in and measure. And here you can see the edematous, thick edematous uvula and palate, which is obstructing the airway. And here you can see adequate posterior airway space at the level of tongue base along with the epiglottis, and you can see. This we can say it's a thin soft palate with the adequate space of the tongue base, but little of adenoids and its pharynx. It's a type 1 collapse, retropalatal collapse. We can see the thick edematous palate which is blocking, and adequate space at the level of tongue base, and you can see the epiglottis nicely. And it's a type 2 collapse, tongue base, retropalate both is getting obstructed, and very fast. lot of dice videos of the epiglottic collapse. Here you can see how the epiglottis is positioned and it is touching the posterior wall along with retropalatal collapse. The tongue base is not coming and blocking the airway. And you can also see how severe the retrognathia in this patient. Still, the tongue base is not blocking. Here also you can see this is more severe than the previous patient, and you can see the tongue base. It's almost touching the posterior wall, but the epiglottis is not touching the posterior wall. And you can also see the palate is also thin, but there is very narrow posterior space at the level of palate. So basically, this is a tongue which is pushing the palate and epiglottis because of retrognathia, and also the tongue volume is also a little higher. And here you can see the beautifully described by Gus, the salpingo-pharyngeal hypertension, which can also be seen in dynamic MRI in axial view. You can see the huge tonsil, huge salpingo-pharyngeal fold which is blocking the airway. And another beautiful part of dynamic MRI is we can assess the palatal phenotype. What Vikas was discussing, the funnel type and tunnel type, and the thickness of the palate, and also, as I told you, primary or secondary palatal collapse can be assessed. Here you can see the posterior end of the hard palate and how the velum is structured, and here you can see this is a tunnel shape. You can see how the posterior space at the level of velum. And another phenotype of palate, you can see how straight it is and sudden drop in the soft palate. And here you can see the shape of the tongue itself. This is a lower tongue base collapse. You see the palate and how obtusely it is positioned, and still it is thick and edematous. It is not just a secondary palatal collapse, it is a primary palatal collapse. So the next thing which I would like to share is on DICE, the sleep endoscopy, beautifully discussed by Sandeep. 1991, Croft and Prindle introduced this direct sleep endoscopy. Later, the nomenclature and word classification is brought up by Kesarian and his colleagues. So there are three key features of potential use of pharmacological agent for sedation and target depth of sedation and endoscopic evaluation of the upper airway. Few clips which I would like to show and share and compare with dynamic MRI is anteroposterior collapse or DICE here, and how we see in a dynamic MRI the anteroposterior airway collapse which is happening. You can see the shape of the airway space behind the palate. You can nicely compare with the lateral collapse of the DICE and lateral collapse happening in a dynamic MRI of the same patients. And circular collapse, where both the anteroposterior and lateral wall collapsing, and same in a dynamic MRI, you can see a circular circumferential collapse happening at the level of velum. Primary epiglottic collapse, where we can nicely see the vallicular. Same in a dynamic MRI, vallicular has been seen, and so broadly speaking, both are complementary, and almost 90% the diagnosis of what we get it in dynamic MRI, we can see it in DICE. There is about 10% difference in dynamic MRI and DICE, where we may additionally diagnose in both the conditions, which may miss in another condition, another procedure. So we broadly use both classification, we all know this and discussed. So the comprehensive airway analysis and reporting, what we have brought up with Vikas and Srinivas Kishore is VSV DICE scoring system, and Vikas briefly said. So the drug we are using, and this monitoring whether we have used it or not, what is the lowest oxygen saturation went down. From the nose, we are saying both dynamic and static obstruction, both the straight or deviated septum, whether the septal description further, is there any septal swell body, and what about the inferior middle turbinate hypertrophy, and the nasal cavity component of mucoid discharge or polyp or any other pathology. The nasopharynx, about the adenoidal hypertrophy, velopharynx, as he said, upper velopharynx and lower velopharynx, and where the lower velopharynx we have circumferential collapse, where upper velopharynx we can't have a circumferential collapse. Oropharynx also we broadly classified as anterolateral, that is tonsil hypertrophy, and behind the posterior pillar or the posterior pillar is included, that's the lateral wall behind the tonsil can also come and collapse. That's we call it as posterolateral wall collapse. Tongue base, upper or lower or entire tongue base, and also in further classification whether it is muscular, lymphoid or both. And still in both classification we say only about anteroposterior collapse, and we come across in few patients lateral collapse also of the tongue base. Hypopharynx and is lateral hypopharyngeal wall collapse is yes or no. And epiglottis is being influenced the larynx and supraglottis obstruction. And epiglottis also not just anteroposterior collapse, whether there is any lateral collapse is also there. The epiglottis also being cardiac. Intervention dyes has been discussed after closure of mouth along with Eschenbach's manners or with nasopharyngeal airway or with changes in the position variation, whether head rotation or head and body rotation. Cramp-coded dyes with lateral obstruction. It's all being put together. All being put together to bring out the report for that particular patient. So as he rightly said, this is not a simple classification system, will not be able to tell us clearly what is happening inside the patient. So this kind of detailed report will tell you what is actually happening and how we can decide what surgical management we can give to the patient. And couple of decades back itself has been clearly explained that MRI objectively quantifies the volume of the tongue, soft palate, parapharyngeal fat pad and lateral pharyngeal wall, which has been not able to assess with the new sleep endoscopy. And here you can see how much it's being reduced after simple weight loss, how much the airway space has been increased. And another paper a decade back clearly says real-time 3D MRI of the pharyngeal airway with synchronized recording of the physiological signal is feasible and provide valuable information about the site and nature of airway collapse during natural sleep. That's the biggest advantage of dynamic MRI. CT scan, yes, it produces excellent resolution of images to evaluate both the soft tissue and the osseous structure. It produces axial, coronal and beautiful sagittal reconstructions. Volumetric reconstruction and three-dimensional imaging is also possible. Here you can see how is the airway during regular breathing and how it is getting obstructed during snoring and OSA. And we can bring out 3D printing model with that CT images so that it will be helpful during skeletal surgery. 3D computed tomographic evaluation of the upper airway space of patients undergoing mandibular dissection or surgeons for microphalangia. It's a beautiful paper, you should all read about it. And that gives you insight about how all we can use that to interpret. Another important area is computational fluid dynamics, aerodynamic flow characters of the upper airway, which allows and describes the regional flow and pressure profile in the upper airway. It is more sensitive and accurate than anatomical parameters, alone in evaluating the effect of airway restrictions which is happening in OSA patient. Here you can see, together with 3D upper airway image models, we will be able to provide a more comprehensive understanding of the pharyngeal obstruction. So these are the pressure points which has been marked in more red and orange color. So when we use it along with CPAP, we will be able to understand how much maximum pressure is needed to open up the airway. So dynamic MRI and DICE both have significantly advanced our knowledge and understanding of OSA and airway geometry. Many recent advancements in evaluating the site and pattern of obstruction helps us to improve the surgical outcome. And ultra-low dose CT evaluation, as I just showed you the images, in various phases of natural sleep during snoring and sleep apnea may help us to identify the site of obstruction more precisely. And a comprehensive DICE reporting system is very much helpful in assessing the patient and choosing the right surgery procedure.